Hello, welcome to our presentation. My name is Bryson Parker.
And I'm Jamal Magoti, and today we're going to talk about ADHD.
So, what exactly is ADHD?
Attention Deficit Hyperactivity Disorder, or better known as ADHD, is a mental disorder that affects an individual's ability to focus, causing them to move around more frequently. They may also have trouble controlling their impulsive behaviors.
Attention Deficit Hyperactive Disorder, or ADHD, is a neurodevelopmental disorder that is believed to be caused by a genetic predisposition or by various fetal exposures and epigenetic changes in utero. According to the CDC, there were 6 million cases of ADHD diagnosed in children 3 to 17 between the years of 2016 and 2019.
So, a little history on ADHD. ADHD dates back to 1775 when Dr. Melchior Welker described ADHD as a syndrome in a German textbook. Over the 19th century and into the early 20th century, it will be described in various literature as a mental instability or a defect of moral control.
In the 1930s, psychiatrist Charles Bradley showed that the drug, Benzedrine, could reduce the hyperactivity component of ADHD. As we moved into the 50s, the US FDA approved methylphenidate as a treatment for depression and narcolepsy. In the 1960s, there was a movement towards parental training treatments, and simultaneously utilizing methylphenidate became indicated for behavioral disorders in children.
Throughout the 70s, 80s, and 90s, the Diagnostic and Statistical Manual of Mental Disorders underwent a number of changes in how it recognized ADHD. First, in the 70s, the DMS described the hyperkinetic connection. Then in the 80s, it moved to operationalizing the diagnostic criteria. And finally, in the 90s, there was a refining of the disorder. Another important movement of the 90s was recognizing ADHD as a valid disorder in adults.
As we moved into the 2000s, the CDC moved to describe ADHD as a serious public health problem. There was also a development of long-lasting stimulants and non-stimulant medications getting approved.
Finally, in the past decade, cognitive behavioral therapy for adults has become more widespread. Scientists have also discovered some of the genomic insertions and deletions that play a role in ADHD, and they have also confirmed that ADHD has a molecular polygenic background.
Now that we know the history of ADHD, we can begin to move into what is known now. So, ADHD is characterized by a trio of symptoms: inattention, hyperactivity, and impulsivity. These symptoms often present in 3 different ways. An individual can have a predominantly inattentive presentation, a predominantly hyperactive impulse presentation, or a combination of the two.
So, let's examine the parts of the brain and some of the various areas affected by ADHD. Individuals with inattentive presentation have a hard time finishing tasks, organizing tasks, paying attention to details, and following along to instructions or conversations. The lack of both selective and sustained attention of this symptom are caused by inefficient processing in the dorsal anterior cingulate cortex, pictured here in red, and the dorsolateral prefrontal cortex, pictured in green.
Individuals with a hyperactive impulse presentation tend to fidget and talk a lot. They struggle to sit for a long time and struggle with impulsive behaviors. The hyperactivity portion of this syndrome is related to the prefrontal motor cortex, pictured here in yellow, and the impulsivity component is related to the orbital frontal cortex, pictured here in blue. People with a combined presentation present the 2 types above equally.
So, how exactly are pathways in these areas of the brain causing the symptoms associated with ADHD? Well, people with ADHD have hyperfrontality, or an insufficient activation of the prefrontal cortex, the area responsible for tasks of attention and problem solving. This results to inefficient tuning of information processing in prefrontal circuits. There are 2 neurotransmitters that are associated and have been linked with this insufficient activation. Those are norepinephrine and dopamine.
To give further background, when a neuron receives a signal, it also receives input from dopaminergic, pictured in blue, and noradrenergic, pictured in green, neurons too. These extra inputs are responsible for tuning the incoming signal. Specifically, norepinephrine is responsible for strengthening or tuning into the signal from relevant cues, whereas dopamine is responsible for weakening or tuning out of irrelevant cues. Now we're going to look at how dopamine and norepinephrine accomplish this.
As stated before, norepinephrine has been shown to increase sensitivity to relevant cues, whereas dopamine has been shown to reduce sensitivity to relevant cues. Slightly separate mechanisms, but generally fulfilling the same goal. The receptors associated with these two neurotransmitters are alpha-2A adrenergic and the D1 receptor.
Both of these are G-coupled proteins receptors. Structurally, the transmembrane receptor is bound to an intracellular heterotrimeric protein made up of an alpha, beta, and gamma subunit. Generally, when an agonist binds to the receptors in the alpha subunit, it exchanges bound GDP for GTP. Consequently, this activates the complex. This causes the other two, beta and gamma subunits, to dissociate from the alpha, and the activated alpha subunit can go on to activate one of 3 different signaling pathways, depending on the type of GPCR. So how do these neurotransmitters and receptors actually function?
In the prefrontal cortex, dopamine, shown here in cyan, binds to D1 receptors, shown in green. When dopamine binds, the alpha subunit in yellow exchanges GTP in cyan for a GTP in purple. The D1 receptor is a G-alpha S subtype, meaning that the activated alpha subunit goes on to activate adenylyl cyclase from gray to blue, which goes on to catalyze the production of cyclic AMP in purple from ATP in cyan. The cyclic AMP then goes on to bind the hyperpolarization activated cyclic nucleotide gated channel, HCN, causing it to open. The opening of the HCN channels, especially if excessive, will lead to leakage of the signal, thereby shunting it out of the spine. This will result in the dissipation and/or weakening of the signal.
By contrast, in the prefrontal cortex, the norepinephrine, shown in purple, or noradrenergic agonist, binds to the alpha-2A receptor. So when norepinephrine binds, the alpha subunit, shown in yellow, exchanges its GDP, shown in cyan, for a GTP, shown in purple. The alpha-2A receptor is a G-alpha-I subtype, meaning that the activated alpha subunit goes on to inhibit cyclic AMP formation. More specifically, any cyclic AMP that might be bound to an open HCN channel will be converted back to ATP, unbinding it from the channel and consequently closing the channel. Closure of the channel allows the signal to go through the spine and down the neuron, thereby strengthening network connectivity with similar neurons. So, in general, in the prefrontal cortex, stimulation of alpha-2A receptors strengthens an incoming signal.
As stated before, together, norepinephrine and dopamine strengthen the signal from the relevant cues and decreases noise intensity, allowing appropriate activation of the prefrontal cortex in response to cognitive tasks of attention and problem solving. However, in ADHD, there is low tonic release of both norepinephrine and dopamine, leading to insufficient activation in the prefrontal cortex, which then presents itself in the trio of symptoms mentioned before.
So now that we know the way in which these pathways act in both ADHD and a non-ADHD brain, we can talk about some of the drugs that are utilized to correct these mechanisms. So treatment for ADHD can be divided into 2 major categories: stimulant treatments and noradrenergic treatments.
Stimulant treatments are those that aim to increase the levels of dopamine in the synapses in the prefrontal cortex. They do so by targeting the reuptake inhibitors for dopamine. But what is reuptake?
So basically, after a neurotransmitter, in our case dopamine, binds to a receptor and starts a signal cascade, it does not stay bound for a long time. Instead, it disassociates and is taken back into the presynaptic neuron via a special transporter called a dopamine reuptake transporter, or DAT. At normal physiological conditions, this serves to avoid overstimulation of the receptor by dopamine.
Stimulant treatments target dopamine reuptake transporters to prevent the reuptake of dopamine, allowing it to stay in the synaptic cleft for a much longer time and consequently allowing it to keep on activating the receptors on the postsynaptic neuron.
Noradrenergic treatments are those that aim to increase norepinephrine levels in the synapses of the prefrontal cortex. There are 2 main types of these treatments. The first, selective norepinephrine reuptake inhibitors, work similarly to stimulant treatments, with the exception that they target norepinephrine reuptake transporters. This achieves the same effect of allowing it to stay in the synaptic cleft for much longer and consequently allows it to keep activating the receptors on the postsynaptic neuron.
The second type, alpha 2A adrenergic agonists, work slightly different. They actually bind strongly to the alpha 2A receptors instead of the endogenous norepinephrine, which allows constant activation of the noradrenergic signaling pathways in the PFC.
We're now going to look at how these different drugs actually work, with a special focus on methylphenidate and amphetamine as stimulant treatments, atomoxetine as a selective norepinephrine reuptake inhibitor, and clonidine as an alpha-2 adrenergic agonist.
First, methylphenidate and atomoxetine. Although these two belong to different treatment classes and target different reuptake inhibitors, their mechanism of action on their respective targets is the same.
Both methylphenidate and atomoxetine, shown here in red, prevent the reuptake of their respective neurotransmitters by binding to the reuptake inhibitor, shown in orange, allosterically, and causing a conformational change that makes it impossible for either dopamine or norepinephrine, shown here in purple, to be transmitted back into the synaptic cleft. Instead, the norepinephrine or dopamine can then go back and bind its receptor again.
Amphetamine, although also a stimulant treatment, has a different mechanism of action. Unlike methylphenidate, amphetamine, shown here in green, binds the reuptake transporter orthosterically, that is, at the site where dopamine would usually be transported from. This in effect works to also inhibit the transportation of dopamine back into the presynaptic neuron.
Finally, clonidine, shown in dark purple, as mentioned before, does not target the reuptake transporters at all. Instead, being an alpha-2A adrenergic agonist, it goes on to bind the alpha-2A receptor, shown in green, strongly and causes a prolonged activation of the signaling cascade.
Current research is being conducted into utilizing two of these medications with one another. Promising results have already been shown. There have also been a great acceptance on behavioral therapies to treat ADHD, with positive results shown around children incorporating fidgeting to improve memory and exercising to boost energy and motivation.
That's it.
Thank you for coming to our